So my name's Dan Press. I'm a cognitive neurologist. I have one foot in the movement disorders world and one foot in the cognitive disorders world. And we're talking today a lot about the cognitive aspects of Parkinson's disease. But I thought I'd frame this more in terms of just what we know about medications and lifestyle interventions to help all our brains age well, whether we have Parkinson's disease or not. So this is there'll be times when I talk specifically about Parkinson's disease, but a lot of this will be for all of us, both caregivers and patients with Parkinson's disease. So a couple quick logistics. I don't have any disclosures to make. That basically means that everything I present today will be my honest opinion and not the opinion of some pharmaceutical company or something like that. I'll just quickly define dementia, a term that I'm not going to use much at all, but you hear it a lot, so I think we should at least take a second to say what it is. So dementia is a term that we use when someone has enough memory loss that impairs their day-to-day function. Dementia doesn't speak to a cause. You can have dementia from Parkinson's disease, from Alzheimer's disease, from vascular disease, from a number of different causes. But whenever you have enough memory impairment that it prevents you from doing your day-to-day function, that's what we call dementia. Parkinson's disease can lead to dementia, but it does not always, and many times does not. And Parkinson's disease can cause cognitive symptoms that aren't enough to impair your day-to-day function. So that would be Parkinson's disease, cognitive symptoms, but not dementia. All right, well, with that as a quick, I couldn't help but think of Muhammad Ali's just recent passing. He had this great quote. It says, "Impossible is just a big word thrown around by small men who find it easier to live the world they've been given than to explore the power they have to change it. Impossible is not a fact, it's not an opinion. Impossible is not a declaration, it's a dare. Impossible is potential. Impossible is temporary. Impossible is nothing." That's a pretty cool quote by Muhammad Ali as he beats the you-know-what out of the Fantastic Four, the Fab Four there. All right, so just as a quick overview, I'm going to talk a little bit about the demographics of memory loss and what's happening just in demographics across the world, really. It's really remarkable. We're going through some radical changes for our planet. Then I'll talk a little bit about what I mean by brain disease plus vascular is worse than brain disease plus vascular. It turns out that's a really important thought about how we can keep our brains healthy as we age. And then I'll talk a little bit about some evidence that we're actually making headway here, that there's a relatively optimistic story. So let me start off with demographics. So, one of the odd things is why do we as humans develop these diseases? Parkinson's disease, Alzheimer's disease, other diseases. Almost all of these brain diseases are due to proteins that misfold and build up in the brain, very gradually over many years, decades really. And it's been a struggle to figure out why we don't have better systems to keep these proteins from misfolding and building up in the brain. But John Trojanowski, a researcher at Penn, is fond of these data, this information. The average human lifespan into the Bronze Age was only around 18 or so. Even in the early 20th century, even just 150 years ago, the average lifespan was only 30 or 40. And just in the last 100 years, there's been this rapid, radical change in our planet of people living much, much longer than we ever have before. So there's really been no evolutionary or genetic pressure to prevent some of these diseases that occur in the 50s, 60s, and 70s, and 80s, and 90s, because no one lived, or so few people lived to that age over the history of humanity, that it really was a non-entity. Even if you account for people dying in childbirth and infant mortality, it was exceptionally rare for people to live to be 60 even, say in 1800. So we're really in a rapid demographic switch. And in fact, for the first time in human history, there are now more people over the age of 65 than there are under the age of 5. Our planet we are all living longer, and it's leading to these disorders. And these disorders all increase with age, unfortunately. so that someone who's 65 has a 10-year risk of developing memory loss or dementia of only a few percent, but someone who's 75, it creeps up to 7 or 8%, and when they get to be 85, it might be 10 or 15%. So because these demographics, if you work your way through, the number of people with memory loss, especially Alzheimer's, but also Parkinson's and other causes of memory loss, is going to be rapidly increasing over the next 30 to 40 years. In fact, it may even double. So Brookmeyer showed that if you take 2010 as a starting point, Alzheimer's and other causes of memory loss might be currently present in about 4 million people in the United States. But in 2047, that number is going to go up to 8.6 million. But the good news that Brookmeyer discovered is we don't really have to cure these diseases. We just have to push them back in time some to rapidly decrease how prevalent they are. If we can delay the onset just by 5 years, we can drop that 8.6 number down to 4.6, largely cut it in half just by delaying memory loss for 5 years. And that doesn't seem like that big a goal, and I'll show you some data that we're making headway on that. But as I said, these diseases build up many, many years, and we have better data for Alzheimer's than for Parkinson's, but it's clear that these diseases, some of the proteins are starting to build up even 10 or 15 years before someone develops memory loss. So in this graph, this line here is the onset of symptoms of someone with memory loss. And looking back in time, 10 years, even 15 years before, you could start to see that there are changes, including buildup of proteins like amyloid. In the graph for Parkinson's disease is largely the same. We know that the proteins that build up in Parkinson's disease, namely alpha-synuclein, build up many years before the motor symptoms begin, probably 15, maybe 20. We're getting a better idea about exactly where they build up and what symptoms people with Parkinson's disease can have before their onset of motor symptoms. Many of you have probably heard this story about the loss of sense of smell. Is this new to you? So it turns out that Lewy bodies can build up in the part of the nerve that carries the sense of smell. So it's really quite common for people with Parkinson's disease to have shown a decrease in their olfactory or sense of smell 5 years, 10 years, even 15 years before the onset of motor symptoms. Now, it usually presents as food not tasting as good or something like that, but these data have now been proven in the forward direction, prospectively, in that if you follow people whose sense of smell is bad but don't have any signs of Parkinson's disease, if their sense of smell is in the bottom 10 percentile, the odds of them developing Parkinson's disease are quite a bit higher. So it's clear that these things are building up for years. And there probably are, I've made it seem as though there's no systems to clear out the proteins. There probably are. It's probably just those systems get overwhelmed gradually over time. So into this challenge of this disease building up for years before, how do we treat it? So, the main way that I think that we think about treating diseases like Parkinson's disease is in this way. We think about there being a pre-symptomatic stage, like I said, that can last for 10 or 15 years, then a stage when symptoms come on, usually motor, but sometimes in other realms, and then the disease gets worse over time. Onto that, we can do therapies, and if the therapies are symptomatic, then it makes the symptoms better, but unfortunately the underlying disease does continue to get worse over time. Does that make sense to people? If we have something that's disease modifying, that actually slows down the underlying brain disease, then that actually has a better and better benefit over time, so that it slows down the progression of the disease. And you can start to imagine what could happen if we could diagnose these conditions before the symptoms come on. What if we took the people who were losing their sense of smell or having some of these very early symptoms, and we had some way of either delaying or clearing those proteins out? That, in essence, would be a cure. That's the biggest hope, I think, is can we diagnose people before they even have the onset of symptoms put them on a disease-modifying therapy, and delay it long enough. Now, if I'm being, are you guys an honest crowd? Can I be honest with you? I worry a little bit about being videotaped, but I will be honest with you. All of us in this room eventually are going to die of something, right? The reality is we're all going to die of something. I'm going to die of something. You're going to die of something. If we prevent Parkinson's long enough so that we die of something else, that's what the cure is. It's not that we put it off forever. We just need to put it off for 5 or 10 years, and other things will catch up with us because everyone in this room is going to die eventually. No one in here is going to make it to 150.
What about the symptoms while we're still living?
Well, that's the thing is we need to start that intervention before the symptoms come on. That's what the cure is. And so if we push it back and then we pass away from something else, hopefully in our sleep with a smile on our face, that's what a cure for Parkinson's looks like. So let me talk about the second thing that I mentioned is brain disease plus vascular is worse than brain disease plus vascular. We know about this much more from Alzheimer's than we do from Parkinson's, but there's at least some initial evidence, and I think that the evidence is only going to get stronger over time, that the story is the same for Parkinson's as it is for vascular disease. And this largely comes from an incredible group of neuroscience researchers in Milwaukee, Wisconsin, who also happen to be nuns. So there's a group of nuns, the sisters, the Holy Order of the Sisters of Notre Dame in Milwaukee, Wisconsin, who allowed their brains to be studied serially over time. They would do all these cognitive tests that many of you in the room have done. They did MRIs, they did PET scans. They allowed spinal taps so that their fluid could be analyzed. And when they passed away, because just like us, they all eventually pass away, they allowed their brains to be examined, to look into their brain, to compare what we could see in the brain with what we could see on the MRI, with what we could see on their cognitive testing, and even with what we thought to be their intelligence at a much younger age by looking even at the essays that they wrote to go into the nunnery and looking at the complexity of their essays. Did they write really super complex sentences using low frequency words, or did they use very simple words and very simple sentences? And what they found, there's a number of studies a number of findings that were found out, but probably the most important one was these nuns, even if they had some degree of brain changes, especially brain changes from Alzheimer's disease, their cognitive impairment wasn't that bad. But if they had vascular disease as well, that combination made them look much, much worse. So put another way, if they were healthy and otherwise, without any vascular disease, their brains could tolerate some degree of brain changes, like Alzheimer's or Parkinson's, without developing a big cognitive impairment. But if they had vascular disease, it was one of these 1 + 1 = 3 scenarios where even a little bit of vascular disease made their cognitive impairment much worse. And in fact, if you look at all the risk factors that we know for developing memory loss, the preventable risk factors are things like obesity, smoking, hypertension, diabetes. Now, if I said to you, what are those risks? There's a disease that being obese and having high blood pressure and smoking and diabetes is a risk for. You would probably say, I know that. That's heart disease. That's stroke, but that's not memory loss. But in fact, each one of those is a risk factor for memory loss. Obesity, smoking, high blood pressure, each of those increases the risk of developing memory loss on the order of doubling, increasing the risk by 50% to 100%. And there are protective factors as well, like cognitive reserve. And this gets back to the nuns who wrote the more complicated essays when they were teenagers and 20-somethings. They tended to do better even when they developed brain changes. And some modest amount of alcohol also seems to be somewhat protective. But you can create risk models for memory loss based on age, education, gender, blood pressure, obesity, cholesterol, whether you're physically active. And those models predict how likely you are to develop memory loss And people who are doing well on all those factors are much less likely to develop memory loss than people who are good on all those factors. And it can be quite a big difference on the order of people who don't have any of those risk factors, only have about a 10% risk of developing dementia in 40 years. But people who have a lot of them, the risk goes all the way up to 29% or 3 times as high. So like as a quick example, if we took someone who's under the age of 47, who's a woman, who's well educated and doesn't have high blood pressure, and her cholesterol is okay and she exercises, her risk of developing memory loss in the next 10 years is under 1%. Whereas if we take someone who's over 53, who's male, who's poorly educated, who has high blood pressure and obesity and a high cholesterol and is inactive, that person's risk of developing dementia is 35%. So it's dramatically different. All right, so with that, that's a little bit about demographics. Let's actually talk about drugs in memory, what we know about drugs that can prevent memory loss and treat memory loss. I'll start with the treatment point first. So there's this chemical messenger in the brain that is particularly important for memory called acetylcholine. And we've known for a long time that acetylcholine was low in people with Alzheimer's disease. In fact, drugs were developed to treat Alzheimer's disease with the goal of raising the amount of acetylcholine. But interestingly, the amount of acetylcholine reduction is even bigger in Parkinson's disease memory loss. And so the 3 drugs that are out there now to raise the amount of acetylcholine are donepezil, rivastigmine, and galantamine. And all 3 are available as a pill form, and rivastigmine is also available as a patch form. So these drugs are definitely in the symptomatic category. So they're like this. They help the symptoms, but you do continue. It doesn't slow down the progression of disease. But here's
the differences among those?
there's really amongst the different pills, they all seem to be about equally as effective. They differ in terms of how much side effects they have. Some people do better on one than another. The main side effects are nausea and diarrhea, and sometimes people get lots of problems with donepezil, but not with rivastigmine, or vice versa. So all 3 of them seem to be equally as effective. So I think if you're on any of them, you're in good shape. But if you have side effects to one, you might do better on a different one. That make sense? And here's some pictures just to show how big this cholinergic deficit is. It's really quite big in Parkinson's disease, dementia, and dementia with Lewy bodies. You can see there's really a marked lessening of acetylcholine in the brain. And this led to the first really big trial of a drug to treat memory impairment in Parkinson's disease with rivastigmine, one of these 3 drugs that's now available as a patch. And indeed, rivastigmine worked. It really helped quite a bit on this cognitive measure in people with Parkinson's disease and significant memory loss. But that's a symptomatic therapy. Are there any drugs that might actually be able to prevent memory loss in the first place? And I think that really, across all these studies, I want to take a few minutes aside to explain to you the challenges and dangers of listening to the media, I guess I would say. So my mom's 76 years old as of next week, and she lives up in Manchester, Mass. And maybe once a month she would call me and she would say, I heard a story on NPR this morning that eating fish prevents memory loss, or drinking red wine prevents heart attacks, or whatever. And each time I would have to say, Mom, that kind of study is just an association study. It means that, yes, people who choose to eat a lot of fish don't develop memory loss, but it may not be the fish, right? It may be something else about people who like to eat fish. Maybe they also like to exercise more, or go to the doctor more, or maybe they're more intelligent, or went to college more, or have lower blood pressure. There could be 1,000 different things separate from the fish that actually lead to that. And so instead of trying to stamp out every story where that is of that flavor of people who exercise more or whatever, instead I tried to explain to her and I'll try to explain to you the difference between an observational study and a randomized trial. So in an observational study, you just observe what people are doing and what happens to them. So you study a group of nurses and you see what they choose to do, and then you see whether they develop problems or not. In a randomized trial, you actually tell those nurses, half of you are going to do X, half of you are going to do Y, and we're going to randomize it. I'm not going to know which one of you does X. You're not going to know which one of you does X. And in that way, in that randomization, we get much better information. And there's no better example of this than the estrogen story. So for a long time, there were a number of observational studies showing that women who take estrogen replacement are 50% less likely to be diagnosed with Alzheimer's disease. Women who choose to take estrogen are 50% less likely to develop Alzheimer's disease than women who do not. Boy, that sounds good. It must be that estrogen is protective for Alzheimer's disease. But I've already warned you, that's an association. The women who choose to take it are not randomized, and they may differ on other things, how often they go to the doctor, exercise, etc. So the NIH set off to do a study to see, is estrogen protective for memory loss, especially from Alzheimer's disease, but also from Parkinson's disease and other causes. And when the NIH set off to do this study, this observational data were so strong that people wondered whether it was even ethical to do the study. They said, wait a minute, you're going to do a study where half the women don't get to take estrogen? They may be at a higher risk for developing Alzheimer's disease. That study isn't even potentially ethical. And others said, well, you know, the data are only observational. We don't know that it's proven. And after a lot of ethical discussions, they decided to go ahead and do the study. It was the Women's Health Initiative memory study, and it studied estrogen and progestin and the incidence of dementia or mild cognitive impairment. And here are the results of the study. So I promised the woman I wasn't going to move. I won't. I don't have to move. I'm going to use my pen. So on this y-axis, this is whether they develop memory loss or not and what the risk was. And this is the people who are on the medicine. That's their risk. And this is the placebo group. So not only was estrogen and progestin not protective, it actually increased the risk. It was the opposite direction, right? So when this study came out, and when I say when this study came out, I mean on the day that it came out, millions of women were suddenly called their doctor, or their doctor called them and said, stop taking it. We were wrong, right? We based our data on observational studies instead of randomized controlled trials. And the randomized controlled trial shows that not only is it not helpful, it may be harmful. So that's the point of why we have to do randomized controlled trials. So that every time you hear a story on NPR, something may be helpful for something. As a smart consumer of science, you should say, wait a minute, is that a randomized controlled trial? Who decided whether they were going to drink red wine, eat fish, do line dancing, live in the Mediterranean, eat a lot of olive oil? Did the people get to decide, or were they randomized? Because in the randomization, in the fact that we flip a coin and say, you go on this one, wait, you go on that one, in that randomization, we account for all these other issues so that education ends up being even between the groups, and every other factor ends up being even between the groups. And if you don't randomize, you're never going to figure it out. All these observational studies can do is generate a hypothesis, generate a question, but it can't be tested until you do a randomized controlled trial. So with that as an example, a number of drugs have been tested in randomized trials to see if they can prevent memory loss, including statins, which neither help nor hurt. Non-steroidals, B12, vitamin E, estrogen replacement, none of them have been shown to work, and estrogen actually has been shown not to work. So it doesn't seem like medicines are getting us there yet. What about other things? What about things like diet? Well, here the story is a little bit better. Again, there were observational data. People who choose to eat a Mediterranean diet have a lower risk. People who exercise have a lower risk. People who do both have even a bigger lower risk. But just a couple years ago, the very first attempt to randomize people was done. And it randomized people to a Mediterranean diet or not. It actually randomized them to two different kinds of Mediterranean diet. One that's very high in fishes, and another one that's very high in nuts, or randomize them to their regular diet. And here's what happened: is the controlled diet, the controlled people had a much higher risk of developing strokes and heart attacks. And the people who had the high nut diet or the high extra virgin olive oil diet equally did much better. And just last year, they've published the results that there is also a similar difference with cognition, so that these people have better memory function than these people now 5 years out. So this is the first randomized controlled trial where the people didn't get to decide whether they went on a Mediterranean diet, and even the doctors didn't. A flip of a coin did, and indeed it did have beneficial effects. So if someone were to ask me what's the most likely beneficial diet to keep your brain healthy as we age, it's a Mediterranean diet, high in nuts, high in olive oil. Similarly, there's pretty good evidence that keeping your blood sugar under control is beneficial. And people who have higher blood sugar levels also are a little bit higher risk of developing memory loss. How about exercise and memory? Here too, there's been a lot of observational data. People who exercise more have a lower risk of developing memory loss. But again, it's easy to see how people who exercise more may do a whole bunch of other things that are healthy. And frankly, it's easy to see how instead of A leading to B, namely exercise prevents memory loss, it might be that B prevents you from doing A. Memory loss may make it harder to exercise, right? So when you see these observational studies, they say people who do A get more B. Do you know what I mean? You don't know. There's a lot of different ways that might be wrong. It might be having B prevented you from doing A, or it might be C caused A and B. I'll tell you one last one as a good example of this. So when I was in medical school back in the 1300s, a study came out like maybe 5 years before, showing that people who drank a lot of coffee had a higher risk of pancreatic cancer. And we're like, oh my God, no one wants pancreatic cancer. This is horrible. Coffee, especially to a group of medical students who are all drinking coffee at that very moment, right? So, and indeed, it is absolutely true. It's been verified that people who choose to drink coffee have a higher risk of developing pancreatic cancer. But it turns out people who choose to drink coffee, at least back then, were also more likely to smoke. And smoking was a very strong risk factor for pancreatic cancer. And if you then did the math correctly and subtracted out the smoking from the coffee drinking, the coffee in and of itself had no risk factor at all. So C, smoking, caused both A, to drink coffee, and was associated with both A, coffee drinking, and B, pancreatic cancer. So these are all the different ways that an observational study can lead you astray. So it's something else may be the driving factor, or the thing that came second may have actually prevented the thing that you were looking at. These are all the tricks that you need to know when you hear these stories on the radio. But finally, probably the first good randomized controlled trial of exercise at older adults who didn't have memory loss. They were randomized to either just doing some stretching in a chair or really exercising where they got their aerobic exercise. They got their heart rate elevated by walking for about 30 or 40 minutes, 4 or 5 times a week. And what they found was that literally the size of the memory part of the brain, the hippocampus, got bigger in the people who exercised versus the people who did not. And finally, there's been some tantalizing early evidence, although not great evidence, that mental activity, just like physical activity, also in a randomized controlled trial may lead to better outcomes, with those who do more mental activities showing a less decline than people who are randomized to not do mental activities. But there's some concern about whether it generalizes from the exercise that you do. This is the argument that if someone does crossword puzzles all day, every day, they may keep up their crossword puzzle ability, but they may not be able to balance their checkbook. So does it generalize across cognitive functions? There's a lot of studies going on right now to try to figure that out. But we think there's at least a little bit of evidence that if you do different kinds of cognitive exercises in different areas, that might be particularly good. And if you combine this with exercise and nutrition, you might be able to generate a program that really is more powerful than any one of the interventions. In fact, that's really the whole idea of the Brain Fit Club. So it looks to try to measure your brain health index in terms of how well you're doing on all these things, from balance to exercise to cognitive exercises. And then it individualizes a plan to treat you using education, skills groups, exercise groups, Tai Chi, nutrition groups, to try to really help our brains get more fit. And then finally, it monitors your progress. So it doesn't just take it as a foregone conclusion that that's going to help. We remeasure your brain health, say 6 months or a year down the road, and see whether it's actually working or not. There's a number of elements to the program, from mindfulness to music-based programs. We're starting to investigate using brain stimulation. This is still in the research end, but it's getting closer and closer. We do Tai Chi and memory and attention skills building groups, and we do some evidence-based computerized cognitive training. So that's a little bit about how brain disease and vascular is worse than brain disease and vascular, but also the positive side of that if we treat those vascular things and we keep our brain healthy, that might be beneficial. And let me try to show you some evidence that we actually are making headway on that. So this has been an intriguing question that's just come out over the last few years, but the data are now pretty clear that we are bending the curve. We are actually starting to make headway here. So what this shows is that someone who's between the age of 60 and 69, their odds of developing memory loss back in 1990, in the coming, say, 5 years, were 1.3%. But it's come down. Even 10 years later, it was down to 1.1. And the people who were even older, who turned 80 back then, they had a 31% chance of developing memory loss. But 10 years later, that had dropped to 26. And that's not just one study. It's now been it's actually 4 studies that have shown this gradual decline in the risk of developing memory loss. So let me be careful about this. I said that demographics are working against us as a planet. There's a lot more 90-year-olds now than there were 30 years ago. But the people who turn 90 now are more likely to not have memory problems than they were 30 years ago. Does that make sense? Yeah. And we really think that the main driver of that is we're not just living longer, we're taking our blood pressure medicines and our cholesterol medicines, and we're exercising more. We're even getting more education than we were 30 or 40 years ago. And that really does seem to be bending the curve. And remember, we don't have to bend the curve forever. We just have to bend the curve by 5 years to really make the risk of the total number of people with memory loss come way down, even in half. So I thought I'd finish up just with a few pointers, maybe 5 suggestions for people with Parkinson's who have cognitive or mood symptoms. The first was going to be to watch your medication. So we've talked a little bit about how medicines that raise the amount of acetylcholine are good. Unfortunately, medicines that reduce the amount of acetylcholine are not only bad, they're also available over the counter. So I think people with Parkinson's need to be very careful about over-the-counter sleep medicines in particular. So all those medicines that end in PM, Tylenol PM, Advil PM, those are all quite bad for your brain. Those all have a drug in them called diphenhydramine that blocks acetylcholine. That works the opposite of the way that we were talking about trying to increase the amount of acetylcholine. So watching your medicines very carefully, letting your doctor know if you're going to make any changes to your medical regimen is really a good idea. So we talked about the importance of staying physically and mentally active. I think the data for these are growing stronger literally by the month. And so all these boxing programs and dancing programs and golfing programs and Tai Chi programs are undoubtedly powerful benefits to your brain. If any of those were available in a pill form, that pharmaceutical company would be a $1 billion company. They'd be selling those drugs like wildfire. If something changes, let your doctor know. So people with Parkinson's are more sensitive to even simple things like bladder infection or a pneumonia or something like that. And sometimes the way it shows up is with a sudden onset of worsening cognitive function. So that's something to pay attention to. And pay attention to your mood as well. Although I focused on cognitive function, there's clearly a strong relationship between mood and cognitive function. And keeping your mood and your spirits up is very important. There are both therapies and medications that can help if mood problems become significant. And those things probably help not only on mood, but maybe even on cognitive function. And I've given this presentation before, and I used to always end with saying, live well. That's the point of life, is to live well. But of course, Muhammad Ali said it much better than I did. He said, don't count the days, make the days count. And I think that's really a lesson to live by, really for all of us, both those who are dealing with Parkinson's disease and those who are not. So with that, I'm going to finish up and say that we've all been doing our mental exercise by following me through these graphs, by trying to think in terms of observational studies, by learning about the difference between disease-modifying and symptomatic therapies. So I want to end there, and I'll take some questions. Thank you very much for your time and your attention.